Hi, everyone. My name is Amy Kontorovich. I'm an associate professor of medicine and cardiology at Mount Sinai, and I'm here today to talk to you about cardiac sequelae in long COVID. So early in the COVID-19 pandemic, it became evident that cardiovascular disease was occurring in the setting of COVID-19 infections, and that cardiovascular pre-existing conditions were associated with a heightened risk of hospitalization and severe COVID illnesses. And the important cardiovascular phenotypes that became evident as associated with both risk and with outcomes were stroke and hypercoagulable states, arrhythmias, including significant ventricular arrhythmias that were associated with sudden cardiac arrest, myocardial infarction, which may have been related to the hypercoagulable state associated with COVID infection, venous thromboembolism and pulmonary embolism, as well as a COVID-related cardiomyopathy that may or may not be related to episodes of discrete myocarditis and pericarditis, where the pericardial sac around the heart becomes inflamed, associated with sometimes acute and sometimes chronic complaints, including chest pain. And there was a convergence in the spring of 2020 of reports of these cardiovascular manifestations of acute COVID-19, as well as the reports of long haul COVID, and that's what we're here to talk about today. And the persistent symptoms among long haulers were predominantly ones that are classically labeled as cardiac symptoms. So we're going to talk about what those are in a few slides. But I think this temporal association in both the academic and mainstream literature created some potential for confusion for both patients and providers to disentangle the objective associations with cardiovascular disease with the reports that were emerging from patients related to their symptoms. And so over the last 3 years, many studies have been reported in association with long COVID. And in this early study reported in Nature Medicine, 13% of patients reported more than one or more symptoms at 4 or more weeks following their acute COVID illness. So this was one of the earlier studies that confirmed that there was a very high proportion of individuals who were experiencing long COVID. And notably, 50% of the symptoms that were reported were in a cardiac category. So what are the lingering cardiac manifestations of COVID-19? Well, in this subsequent report that was assessing symptom burden and categorizing it by different systems, including systemic symptoms and reproductive symptoms, cardiovascular, musculoskeletal, etc. The cardiac symptoms that were prevalent, and these crossed multiple categories, included chest pain and chest tightness, palpitations, tachycardia, bradycardia, fainting, and these are the symptoms that many individuals in society classically associate with heart attack. So people think of having chest pain as indicative of a heart attack, or at least that it's a potential indication that one is experiencing a heart attack. And so the lived experience of having these symptoms can be very frightening, anxiety provoking, and certainly requires medical evaluation. Now, the etiologies of these cardiac symptoms vary. So I mentioned that early in the pandemic, there were cases emerging of structural and functional abnormalities associated with COVID infection, including conditions like myocarditis or a true myocardial infarction due to a thrombotic event or a plaque rupture in the coronary artery. And those certainly can cause the cardiac symptoms of chest pain and palpitations and shortness of breath. And those are listed here under cardiovascular sequelae. So COVID can cause myocardial infarction, cause myocardial injury, myocarditis. And the etiology for those events, it's not well known with certainty, but there are a number of theorized mechanisms, including direct viral toxicity to heart cells, such as endocardial cells that line the walls of the heart blood vessels, inflammatory mechanisms with infiltration of inflammatory mediators into the myocardium and the vasculature, thrombosis and vasculitis related to endothelial dysfunction and hypercoagulable state, as mentioned previously, as well as autoimmune response, where there is a mimicry of the antigens that causes host immune cells to attack native tissues. And obviously, these manifestations can lead to long-term cardiovascular outcomes, such as recurrent hospitalization and acute coronary syndrome, stroke. All of these I've mentioned already. But there are a subset of patients who experience ongoing symptoms. And these etiologies that we think of classically within the cardiology space preceding COVID, acute coronary syndrome and AFib, while they can cause symptoms, the nature of the symptoms that were emerging following long COVID had a unique characteristic. And one of the conditions that's listed here is something called POTS, which stands for positional orthostatic tachycardia syndrome. And I'll be spending the second half of the talk today focusing on that condition, so I won't dwell on that right now. Another pattern that emerged relatively early in the long haul COVID lore is that the episodes of long COVID were more likely to be occurring in individuals who had either an asymptomatic or a mild initial COVID infection. And by mild, we don't mean that the symptoms weren't present or they weren't significant, but they weren't significant enough to require a hospitalization or supplemental oxygen. Whereas patients who did require hospitalization, perhaps needing ICU care or not, they were the ones that were more likely to have structural or functional cardiac manifestations of the infection, consequences of the infection, but less likely to have the classic long haul COVID syndrome. So just to talk a bit about the post-COVID myocarditis, this was something that was rampant in the headlines, especially around discussions of athletes and return of play after COVID infection. It was a topic of a lot of concern relating to college athletic programs. And we saw firsthand how this attention to this entity that many people before COVID had not heard of raised a heightened awareness among the patients who were most symptomatic in the setting of long COVID. So what is myocarditis? Well, myocarditis is typically caused by a viral infection of the myocardium, meaning direct myocardial infection of a virus that then leads to a classic cascade of an innate immune response followed by activation of an acquired immune response. And patients who experience myocarditis are typically symptomatic. Sometimes the initial presentation can be a sudden cardiac arrhythmia. It can cause sudden cardiac death. It's responsible for heart failure. It's responsible for about 15% of the dilated cardiomyopathies. About 12% of people will experience a sudden cardiac death in the setting of acute or fulminant myocarditis. And those who recover from the acute phase will either have a complete recovery or they will have remnant of the myocarditis with some type of inflammatory or fibrotic cardiomyopathy. And before COVID was ever on our radar, we knew that this was a condition that was often caused by viruses, most often common pathogens that are associated with the common cold, such as adenovirus and enteroviruses like Coxsackie virus, but also could be caused by other infectious agents and non-infectious etiologies, such as immunologic syndromes and hypersensitivity disorders. And although there were many groups that looked into the question of direct myocardial infection by SARS-CoV-2, the virus that causes COVID-19, including autopsy series, ultimately the best study that I'm aware of is one that was reported in 2021, where they performed a prospective assessment of individuals following COVID-19, those who had recovered and those who had not, based on serologies and symptoms. And they performed cardiac MRIs on these individuals and interpreted them in a blinded fashion. And what they found was that there were some abnormalities present in the myocardium of both the seropositive and the seronegative populations, but there were no differences in the distribution of those abnormalities and the severity of those abnormalities. So the conclusion was that it does not appear that COVID, by and large, causes unique structural myocardial changes in the hearts, regardless of the symptom burden. And what the way to interpret this is that it's very likely that these changes that we're seeing, especially among the seronegative patients, but probably also among the seropositive, represent a degree of variation that exists in the general population and may or may not be related to the virus itself. So to date, there is insufficient evidence that myocardial injury is what is driving the high prevalence of cardiac symptoms in patients with long COVID. So far, there's been no studies that show that patients with long COVID have more structural or functional impairments in the heart compared to people who don't have long COVID. So what do we know about these cardiac symptoms? Well, going back to this study that looked at the characterization of an international cohort by symptom clusters, they also reported that 86% of the patients experienced relapses, and those were typically triggered by exercise or some degree of physical or mental activity or by stress. And the nature of the symptoms, the characterization of relapses, the triggers, all points toward a condition or a category of conditions called dysautonomia. Dysautonomia is an umbrella term that encompasses a number of diagnoses associated with autonomic nervous system dysfunction. And the symptoms that you're seeing listed in these bubbles are the common symptoms that are reported in dysautonomia, including chest pain. And they're also the symptoms that you saw on the previous slide, many of which occur in long COVID. So it didn't take long for the scientific community and the medical community to catch on to this association. There have been many reports, case series, and case reports that have now identified dysautonomia as a prevalent subtype of long COVID. And of dysautonomia, the one that's easiest to characterize because there is an objective diagnostic test for it is postural orthostatic tachycardia syndrome, or POTS. So in the scientific literature, there's a skew toward reporting of the POTS, I think because it's easier to diagnose, whereas we don't have one uniform diagnostic test for dysautonomia. So dysautonomia is a problem of autonomic nervous system regulation, and our autonomic system is comprised of a sympathetic and a parasympathetic component. The sympathetic nervous system releases neurotransmitters that are responsible for activating various responses in our physiology, including dilating the pupils, helping to release our fight or flight response, so epinephrine and norepinephrine release. It's associated with peripheral vasoconstriction, increased heart rate, and contractility. In balance, we have our parasympathetic system, and our parasympathetic system releases neurotransmitters that decreases heart rate, decreases contractility, constricts the bronchi, stimulates digestion, promotes sleep, constricts the pupils, in other words. And these systems are integrated and interrelated. Now, in dysautonomia, because of an imbalance in those in sympathetic and parasympathetic tone, you have a number of consequences, and these cause the symptoms that are characteristic. So one of the theorized timelines for how this occurs is commencing with excessive gravitational venous pooling in the legs, whether you can see venous stasis or not. And that leads to a decrease in cardiac preload, so less venous return coming back to the heart, which causes, among many other consequences, cerebral hypoperfusion, and then baroreceptor and reflex-mediated sympathetic responses that cause additional adrenaline-like responses. And the chronic exposure to this process also induces the subsequent symptoms of fatigue and syncope, near syncope, headaches, and everything listed here. Now, there are many triggers for dysautonomia, medications high on the list, but also the entities listed here: dehydration, heat, exercise, alcohol. And what I'm showing you in a figure in this image is an example of something called acrocyanosis, and this is common in patients who have dysautonomia with prolonged standing. In this picture, the patient was standing for a prolonged period, and then only the right leg was elevated, and so the left leg, and then brought back down for the photograph. So the left leg, you can see the discoloration throughout the leg. You can see it's reddened, darkened, mottled. The right leg had a restored venous circulation with elevation, and so when you see them side by side, you see the difference. So typically a shower is a classic trigger of dysautonomia because of both the standing and the heat. And you can see that depicted in the infographic here. So the physiology of dysautonomia is thought to relate to alpha and beta adrenergic hyperresponsiveness, which causes an increase in heart rate variability, a decrease in blood pressure with Valsalva, a decrease in systolic blood pressure with tilting, meaning raising up the head of a person and lowering the legs, and the most common, or at least most common reported diagnosis within the dysautonomia spectrum is POTS. And it's proposed to be caused, as I mentioned earlier, by sympathetic neurogenic dysfunction, but also is common in patients with connective tissue diseases because likely the laxity of the venous walls in the lower extremities promotes pooling. And other proposed causes, again, include pseudomotor abnormalities and medications. So the mechanisms of dysautonomia that were well described before the COVID pandemic included things like hypotension, again, increased peripheral venous dilatation and pooling, decreased circulating blood volume, meds, it's a big one that keeps coming up, elevated circulated catecholamines, the so-called hyperadrenergic state, autoimmune conditions, excess systemic histamine, as is seen in mast cell activation syndromes, as well as craniocervical etiologies like brainstem or cervical cord impingement. Now, in COVID, there have been several theories put forth for the mechanisms between COVID, the pathophysiologic connections between COVID and dysautonomia. Number one, the same physiologic relationship that we've seen in other dysautonomic entities, hypovolemia, and in COVID, that may be because of the fever, decreased intake because of poor appetite, and changes in taste from that were reported, a decrease in taste, nausea, excessive sweating, and prolonged bed rest. And that in combination can lead to increased cardiac sympathetic nervous system outflow. Another proposed mechanism is the direct infection of the SARS-CoV-2 virus of the extracardiac postganglionic sympathetic neurons, which can increase sympathetic outflow. Number three would be brainstem invasion of SARS-CoV-2, resulting in increased central sympathetic outflow. And that's something that has also been reported in association with the sympathetic outflow and the brainstem activation in Takotsubo cardiomyopathy. So there's a theoretical precedent for this type of consequence. And fourth, virally induced autoimmunity, directing an immune attack against the host neurons. How do we diagnose dysautonomia? There are many tests that address different manifestations of dysautonomia and different subtypes of dysautonomia. As I mentioned, the easiest subtype to diagnose is POTS, because we have a test called the tilt table test, and this child here is demonstrating how that's done, although it looks a bit barbaric. But basically, this is still the way we do things in 2023. A patient can be strapped down to the table, which can be initially is in the horizontal position and then is tilted up, and patients connected to a heart rate and blood pressure monitor, and then observed for up to 10 minutes in that position with checking vital signs throughout the test. And that can reveal a diagnosis of POTS if the heart rate increases by 30 beats per minute or more over the study period, and the blood pressure does not significantly change. But there are other tests that are included as part of comprehensive autonomic function panels, including sweat test, 24-hour urine test, response to Valsalva, response to deep breathing, and many others. But again, there is no one test that can capture the diagnosis of dysautonomia at large. There's only testing that can diagnose the different subtypes. And so dysautonomia as a category remains in a state where it's diagnosed based on symptom collection, symptom triggers, and context. It's important to recognize that dysautonomia comes with relapses. Patients can have periods where they're relatively well, and then either with a known trigger or without any real clear identifiable trigger, they can flare up and develop an activation or worsening of their symptoms that renders them very dysfunctional or even disabled. And so it's important to know that if someone looks well in your interaction with them as a healthcare provider, it doesn't mean that they don't have this condition. It may mean that they're having a good day. On the other hand, if they are really suffering, it doesn't necessarily mean that they will remain in that heightened state of symptom exacerbation. It's likely, if their diagnosis is correct and it's dysautonomia, that they will have waxing and waning periods of wellness and worsening. So in the spring of last year, the American College of Cardiology released their expert consensus decision pathway on cardiovascular sequelae of COVID-19. And they covered in that document myocarditis, as well as other myocardial involvement. And they also covered dysautonomia. And one of the topics that they addressed within dysautonomia was the notion of deconditioning. And I want to spend a moment just to talk about that. So we've already discussed that the key symptoms of dysautonomia include fatigue, decreased exercise capacity, excessive tachycardia that can cause palpitations or chest pain, and in some people, an overt orthostatic intolerance where they have an abnormality on an orthostatic test. And the working group put forth a proposal that these symptoms lead to diminished activity, avoidance of exercise and physical exertion due to provocation of symptoms, and that played into a phenomenon called cardiovascular deconditioning. And cardiovascular deconditioning refers to a state of decreased blood volume, cardiac atrophy, where the left ventricular masses and volumes are decreased, and that also causes a decrease in stroke volume, causing a decrease in preload, and then compensatory tachycardia to maintain cardiac output. And this phenomenon then promotes worsening of symptoms, further worsening motivation for exercise, further exacerbating post-exertional symptom exacerbation, and decreasing quality of life, and in some cases causing patients to have to stop their work. And then, of course, this is cyclical. So let's talk just for a moment a little bit more about the cardiac origins of dysautonomia. And in this landmark study from 2010, Fu and Levine's group performed cardiac MRIs in patients who had POTS compared to healthy controls. And they demonstrated that patients with POTS had lower blood volumes and left ventricular masses. And unfortunately, they coined this term, the Grinch syndrome for POTS, which has really been a very negative association. But the concept was that, as with the Grinch, the classic Dr. Seuss character, that had a heart that was 2 sizes too small, patients with POTS have cardiac anatomy and morphology that differs from healthy controls in a way that it's smaller. And we've seen a similar phenomenon among patients who have a type of genetic connective tissue disorder called hypermobile Ehlers-Danlos syndrome and the related hypermobility spectrum disorder, where dysautonomia correlates with lower exercise capacity and a greater likelihood of sedentary behavior. Up to more than 80% of patients following the onset of dysautonomia develop sedentary behavior. And when we look on echocardiography, we see a trend toward measurements of left ventricular size as being lower in men and women with dysautonomia compared to their counterparts who did not have dysautonomia. So deconditioning, is it the chicken or is it the egg? the term is somewhat loaded. It can invoke sometimes a feeling of pointing a finger at a patient or shaming the patient, and that really shouldn't be the case, because this has to do with cardiac physiology. And again, you have this cycle of symptom onset and changes in physical activity that then promote the changes in cardiac morphology. And what wasn't mentioned in the previous figure, which is important to add in, is that this process promotes sympathetic activation. And so the more sympathetic mediators that are circulating, that leads to increased heart rate and other manifestations such as decreased GI motility, headaches, fatigue, etc. Now, there is a real world example of dysautonomia and cardiac deconditioning, and that's in spaceflight. So this is a condition that was actually relatively common among astronauts previously, and it was thought to be related to the weightlessness, and the weightlessness causing similar cardiac morphologic changes as I just showed you in the POTS population. And astronauts were returning from spaceflight with orthostatic intolerance, experiencing syncope and resting tachycardia and decreased physical capability. And so the Fu and the Levine group actually were the ones who also performed a study in 2019 that changed the way that astronauts now perform their space flights. So the design was that 12 astronauts were in space for 6 months, and during that period they performed individualized exercise. And upon landing, they received 500 to 1,000 milliliters of normal saline intravenously. And strikingly, none of the astronauts following this intervention had any evidence of orthostatic intolerance or hypotension. They had normal beat-to-beat blood pressure variability, and their systolic blood pressure patterns returned to baseline post-landing. So this laid a good foundation for an intervention in the broader dysautonomia population. So how do we manage dysautonomia in POTS? Management is stepwise, and it's symptom-guided. So it's important to think when you're interacting with patients, have they been through this process? Because if you're seeing people who are reporting a lot of symptoms that might be cardiac, chest pain, shortness of breath, palpitations, tachycardia, hypotension or hypertension, you can reference this flow sheet, which I think is nice, from a study from just a couple of years ago from Olshansky that was related to POTS specifically, not necessarily COVID-induced dysautonomia, but I think it applies here as well. And so it invokes this stepwise process. And at each stage, you reassess whether POTS or dysautonomia is likely. And if it is likely, then you can implement a number of interventions to try to address the symptoms. I know a lot of the audience are physical therapists, occupational therapists, and so the concept of exercise may come up with your patients. And it is important to think about these tips because many of the patients who have dysautonomia have been through frustrating experiences with their healthcare providers, long diagnostic journeys where they may not have been believed about their symptoms or told that their symptoms were in their head. And so that is not the case with dysautonomia. And although exercise can be a trigger, it's important to promote an atmosphere of impactful exercise. And so you don't want to give the patient the impression that you're blaming them for their exercise intolerance. You want to acknowledge that the orthostatic conditions and dysautonomia will cause exercise intolerance and exercise-induced symptom exacerbation. And so you acknowledge that and you develop strategies for working through it. And you explain the physiology. This is something I do in my practice. I explain what the physiology is to patients who have dysautonomia so they can understand why this is happening to their bodies. Dysautonomia treatments, again, avoid triggers of dysautonomia, withdraw any medications that are known to be provoking. Hydration and electrolyte repletion are very important. A good strategy of lower extremity compression garments and lower extremity resistive exercises can help with reducing venous blood pooling and improving preload. And then the key intervention is autonomic conditioning therapy. So all of these entities listed here, many of you on the call may be familiar with this strategy. but it involves a very slow and gradual progression toward a goal of at least 30 minutes of moderate intensity sustained aerobic exercise. Patients will start out with seated exercises, and they will start out with much lower doses, sometimes just 5 minutes of exercise, beginning with a warm up and ending with a cool down. And many of the patients who have COVID-induced dysautonomia cannot even tolerate that degree of aerobic exercise initially. So it's important to to listen to the patient's symptoms and use a symptom-guided approach. And it may be necessary to dial it back even further before they're able to initiate this type of intervention. We do have good evidence that an exercise-based intervention does help with POTS. And we've seen this in our own experience to help more broadly with other forms of dysautonomia. Objectively, the exercise intervention can improve blood volumes, can improve left ventricular mass, and also improve symptom burden and quality of life. So in summary, cardiovascular complications can occur in some patients with COVID-19, but the structural and functional abnormalities that have been reported are primarily in those who've had moderate or more severe acute presentations and are uncommon in the long COVID population. The cardiac symptoms in long COVID are predominantly associated with dysautonomia phenotypes. And dysautonomia is complex and incompletely characterized, but it encompasses a number of diagnoses that are associated with sympathetic neurogenic and/or pseudomotor dysfunction, connective tissue laxity, medications, and probably other likely causes. Cardiac deconditioning is a well-described phenomenon in POTS and other forms of dysautonomia and likely plays a role in some patients with long COVID. Dysautonomia can be managed through multiple interventions, but medications are only needed in select cases. And finally, an intervention that includes physical rehabilitation can be impactful, but must be implemented carefully. I want to thank you for your time and your attention, and I hope you will take this information toward improved care of long COVID patients. Thanks.